Now starting it. There we go. All right. Thank you, everyone, for joining the inaugural JARALL quarterly webinar. Appreciate your time for coming on this evening. We're going to get things kicked off over to our CEO and founder, Dr. Alan Bass, who will go into detail on the differences between BLA and non-BLA skin substitutes in this webinar today. Dr. Bass?
Thank you, Eric. And let me introduce Eric Childress, who is our client liaison. He is basically my right hand when it comes to our different clients. So thank you, Eric, for what you do for our clients and what you did to organize tonight's webinar. So with what's going on in today's world of skin substitutes and how we have LCDs and they're coming and going and changing and non-changing, and how the government and CMS is involved in it, I thought it would be important to do things like this. And these webinars, we're going to have these webinars once a month. And they're going to rotate. So we're going to do every quarter, it's going to be something different. So once a quarter, we're going to do a clinical webinar. Once a quarter, we're going to do a more front office based webinar, how we can help your practice. And most likely in the other quarter, we're going to do more of an industry webinar where we're going to talk about some of the different services and products that are out there in our industry. So let's jump right into it. So what are our learning objectives tonight? So really, what are BLA and non-BLA skin substitutes? What has changed regarding coverage for these skin substitutes? And really, what is the difference between BLA and non-BLA skin substitutes? And if anybody has any questions, Eric is monitoring the questions, and you can, Eric, jump in if you think it's appropriate at that time before we move on, and we'll handle questions as we go on, or if you want to just wait till the end. So non-BLA skin substitutes are exactly what they say. They do not have a biologic license application. And what you're going to see as we get into it a little bit deeper, you're going to see that most of us are using the non-BLA skin substitutes. And those are the ones that are regulated and classified as human cellular tissue-based products. They're not approved for safety and effectiveness is the same way as a BLA is. And the FDA oversight is definitely more limited than for an actual biologic. CMS coverage is separate from FDA clearance and registration. So lacking a BLA, lack of a BLA does not equal automatic coverage. So let's talk a little bit about Medicare's coverage of non-BLA skin substitutes. Medicare covers skin substitutes only when reasonable and necessary under existing LCDs, NCDs, and billing guidance. Now, while there's really no NCD, national coverage determination, and most of the MACs actually coordinate things. And while they'll have separate LCDs, that's how they come up with what would be really an NCD or national coverage determination. Coverage is specifically limited to the specific types of wound. As we know, all these skin substitutes are covered for diabetic foot ulcers and venous leg ulcers. They have defined clinical application, and the coverage is limited when clear failure of standard of wound care is done. So denials are not really for the product itself. It's when you don't follow the standard of care. And the biggest thing that doctors don't do nowadays is 4 weeks of conservative therapy prior to the first application of a skin sub. And the non-BLA products, because they don't go under the scrutiny that a BLA product undergoes, that's why they are under that scrutiny, because they don't have as long studies as BLAs do, and they haven't been the evidence is not there as much as the BLA skin substitute. So what clinical evidence does CMS look for when evaluating the different types of products? Well, CMS and MACs expect peer-reviewed clinical evidence, demonstrated improvement in healing outcomes, and appropriate patient selection. So when we talk about peer-reviewed clinical evidence, that's a lot of the BLA, these long-standing studies that are done, and making sure that the studies have clear defined outcomes that they're looking for. Most concerns when it comes to non-BLA skin subs, small or poor quality studies, lack of effectiveness data, and the evidence extrapolated beyond the study indication. So they just don't do them long enough, more than anything else. And they try to take the data that they get from these non-BLA skin substitutes and show and try to extrapolate them out longer, like a BLA skin sub, and it just isn't there. So the utilization risk, non-BLA skin subs are a high risk category due to the rapid growth in the number of products. And why has there been a large number of these products? Because they don't undergo the long-term studies like the BLA, like a biologic does. The biologic has that license, and the non-BLA, because it's a cellular tissue product, doesn't undergo that, and that's how they're able to get around it. You will notice and we're not going to talk about actual pricing of them tonight, but for non-BLA skin sub, there is a large variation in price and use. And because of this large difference in price and use, that's where we're seeing the overutilization and now the impact of these new LCDs that are coming out. So the non-BLAs are frequently targeted for prior auth, prepayment medical review, and the new model that CMS has brought out now called the WISER model. The WISER model is actually being rolled out in 5 different states across the country. And what they're asking, for in podiatry, is to get prior authorization prior to the use of the skin sub. Now, the rollout is happening, and what's going on now is that you are using AI to get the prior authorization, but if it needs a review, it's actually undergoing review by a real person. And according to the models, like this WISER model, you should be able to get a prior auth for the use of a skin sub within 72 hours. Now, remember, you're not going to be using it for a minimum of 4 weeks anyway. So there's really no rush if you're in one of the states that has the WISER model that you need to worry about, having it the moment the patient hits the door. Let's talk a little bit about documentation and medical necessity. So strong documentation is essential and should clearly show the wound etiology, size, depth, duration. Your documentation definitely 100% must show a failure of conservative treatment. Without that 4 weeks, there is most likely a 100% chance that money is going to be clawed back if you're putting on a skin sub prior to those 4 weeks of conservative therapy. Why did you use a certain product? You have to show your rationale as to why you use that product. So don't let any representative from any company say otherwise. So you must show a rationale for it. You have to have an ongoing response to treatment. You can't just continuously put on a skin substitute week after week if there is not some type of positive response to that treatment. You must show that the wound is improving, the ulcer is improving with the continued use of a skin sub. Now, as time is, when they roll out the new LCD, which was supposed to roll out on January 1st, and it got pulled back, but will eventually, I'm very confident it's going to come out. You're going to be limited to the number of applications you're going to put on. So you're going to definitely have certain limitations on using skin subs. And that's what we talk about, the application limits. Most skin subs are going to be limited to 8 applications. And while you will be able to put them on longer, there will be the need for an addition of a modifier at that time to show that you are exceeding the application limits for that skin substitute. But the biggest thing I must stress is documentation is the primary driver of the denial, not the product choice. You can have very good reasoning for that product. If your documentation is poor, that's where you're going to get your clawbacks. So one of the things that I always talk about, and it's a completely separate lecture, is what's needed in the documentation for skin subs. And there's literally approximately 30 different things that should be listed on almost each and every note that you put on every every encounter. And that's why it's important that you can definitely use templates for these things. But it's not about the copy and pasting. It's not about using an old encounter, create a new encounter. Make sure you do it each and every time. And the biggest thing that you should have more than anything else, and I recently just spoke to an expert in the wound care space, pictures. Pictures are definitely worth 1,000 words. Pre-debridement, post-debridement pictures showing the size of the wound. Yes, you're not going to get depth of the wound, but there are other technologies out there that actually do length, width, and depth of a wound. Let's talk about some billing and coding considerations. You have to make sure that you're using the proper HCPCS code. You have to apply the proper CPT code, and you'll have to talk about the units and wastage modifier when it's appropriate for that certain skin sub that you might be choosing. We're going to talk in a few minutes about the modifiers, the JW and JZ modifiers, how it pertains to BLA skin substitutes. The risk areas, excessive numbers of applications. Like I said, they are going to be limiting the numbers to at most likely 8. One of the things that they realized that they probably got wrong, in my opinion, that they realized they got wrong, is that doctors were choosing the wrong product size for the size of the wound. Because what they were doing for a lot of the skin subs was paying for the entirety of the skin sub between the use, whatever's being used, and whatever's being wasted. So, I would be reviewing charts and I would see a wound that might be, 4 square centimeters, 6 square centimeters, but they were purchasing and utilizing a skin sub that's 20 square centimeters, and it's just not the correct size. They need to be using a product that's more a product size that's more appropriate to the wound size. And to use the rationale that they don't make that in that size, well, then that is the reason that product should most likely not be used for that wound. And you have to also be careful about billing products for non-covered indications. Most of these skin subs, almost all of these skin subs, are covered for diabetic and venous leg ulcers. Those are the only indications. Those are the diagnosis codes that you must have. Over these next couple of slides, I wanted to compare both BLA and non-BLA skin subs. So right off the bat, FDA pathway and reviews. For BLA skin subs, they are licensed under a biologic license application. Non-BLA are not FDA approved, and they are regulated under as a human cellular tissue product or device. BLA is most likely supported by robust clinical trials, where non-BLA have much more limited studies and are more likely product specific as opposed to comparing. Medicare coverage, The BLA skin sub is covered when reasonable and necessary per the LCD or NCD, and the non-BLA is covered only if strict Medicare medical necessity criteria are followed. Like I said, the indications for BLA skin subs are most likely laid out there because they have robust clinical trials on exactly what they were using them for. And the indications for non-BLA skin subs are much more closely scrutinized because their indications are much more narrow. Moving on, for utilization risk, there's a much lower historical risk of misuse for BLA skin subs because they have the, again, robust clinical trials and have exact indications on what they are being used for. The utilization risk for non-BLA, more likely due to the, much higher risk because of the rapid growth of the products themselves. And while it's documentation, standard wound documentation and enhanced documentation for non-BLA is out there, I don't care what you use. You should be using the exact same documentation for both. I think if you use the same for both a BLA and non-BLA, you'll be fine. A BLA skin sub will cost you more, but you are under less scrutiny. The non-BLA may have a lower price and have a larger margin, but you're going to be looked at, and the oversight is definitely there for the use of the non-BLA. When it comes to WISER and the use of prior authorizations, the non-BLA skin substitute is going to be looked at much more closely when getting the prior authorization, while the BLA will not be. When we talk about Medicare classification, again, the BLA is biologic as opposed to the non-BLA is what we call an incident to supply. A flat rate is paid, waste is not paid. We're going to talk about that again in a few minutes. And just a couple of examples, not picking anything in particular. The BLA skin subs, Apligraf, Dermagraft, and the non-BLA, Amnioband, Oasis, Kerasis, Primatrix, Integra, etc. We'll talk again in just a couple of minutes about what is reimbursed when it comes to BLA versus non-BLA. Let's talk a little bit about regulatory and reimbursement differences. BLA products are treated as biologics for reimbursement, with Medicare paying via biologic pricing formula and historically separate payments for waste. That is for biologics themselves. For non-BLA products, are paid as what we call incident to supplies. Only the administered portion is reimbursable. Unused and wasted amounts are not being paid. Now, while the LCD that will regulate the exact products that are covered has been put on hold, this has not been put on hold. So you have to be careful of the size of the product that you're using when it comes to a non-BLA skin sub, because historically you've gotten paid for wastage and now you are not. When talking about BLA products, they have specific Q codes. They, as I said previously, have higher costs and require documentation of failed standard of care, just like you would for non-BLA. The non-BLA fall under different billing categories. The coverage can vary by MAC, and there is much more increasing scrutiny. As we said earlier, BLA products have undergone the highest regulatory review and are reimbursed as biologics under Medicare Part B. So again, there is a payment methodology that came along with BLA products. ASP, average sales price, plus a percentage. Very straightforward. When it came to non-BLA, it's almost like the wild, wild west. You were getting, because of how it was classified, you were getting paid these very large amounts. And again, some examples of BLA products, both Apligraft and Dermagraft. So non-BLA products, you could see I gave you a nice big list here, are not, they don't have a biologic license application, just like I said. They're covered as cellular tissue products. And these are what we call incident to supplies. So every one of the products that we have listed here are a separate incident to supply and paid in that way. They pay you for the product that you've used, the units that you have used, and not any wastage. So if you think it's appropriate to use one of these non-BLA products, you should use it, but know that the appropriate size needs to be chosen. So what's the practical application of this? So again, BLA products have separate payment for waste, and non-BLA products, only the admitted portion of it is reimbursable. Again, I can't say it any more clear than that. Not all products in the market are covered. Medicare contractors list covered products for specific ulcer types, diabetic foot and venous leg ulcers, while 100+ products may be considered non-covered. So it's very important for you to check with your MAC and the LCD. So important points to remember about the non-BLA. I like to repeat things over and over again because I think it's important. Incident to supplies are what BLA products are. They do not pay for waste or unused portions. CMS has updated the FAQs on the JW and JZ modifiers. That Medicare fee-for-service, which is where we are most likely putting these products onto these patients, does not pay for discarded amounts of incident to supply and only for the amount of product that's being used. Some questions. Should JW and JZ modifiers be used when billing for separately payable incident to supplies? Okay, non-BLA products, incident to supplies. The answer there is JW and JZ modifiers are only used when billing drugs and biologics separately payable under Medicare Part B. So it's used for biologics. The JW and JZ modifiers are not appropriate billing for incident to supplies, even if the incident to supplies are paid separately. So you could be paid separately for the non-BLA, but only for the units that were used. It is not appropriate to use the JW and JZ modifiers for incident to / non-BLA products. Like I said, although the LCD that was pulled back, these ramifications of the use of non-BLA skin subs did go into effect on January 1st, 2026. Remember, you can use the product, but don't use the modifiers. What if you use the entire non-BLA skin sub from the package or the container? That's great. For after January 1st, 2025, if the provider or supplier administers an entire non-BLA skin sub, the JZ modifier showing that you've used the whole thing is still not appropriate. These are used for BLA, not the non-BLA cellular tissue products. What if I just use a portion of the non-BLA skin substitute from the package or container? For after January 1st, if you use only a portion of a non-BLA skin sub, only bill for the units that are administered. It's not appropriate to bill for discarded units, and it may not be billed with the JW modifier. Can't say it any more clearly than that. What are the reimbursement rates for non-BLA skin substitutes? Well, here's what we all want to know. While the rates were and reimbursements were out of control for a long time, as of January 1st, 2026, CMS has finalized a flat national rate, approximately $127.14 through 28 cents per square centimeter for most non-BLA skin substitutes. Okay, it doesn't matter whether it's put in the skin sub is put in your office, hospital outpatient, ambulatory surgical center. They're still all incident to supplies. This is the reason we're starting to see physicians now starting to go to wound care centers and letting the wound care centers purchase the products and bill only for the debridement portion of the service. How are non-BLA skin substitutes billed? So a skin substitute, the skin substitute product is reported with the HCPCS code, the A series codes for synthetic or other products, and Q codes were the older products, and the skin sub application procedures, the 15271 through 278 series. That's what's being paid. Medicare pays, like I said, $127 and change for the amount actually applied to the wound. The CPT code for application remains separately payable under the physician fee schedule. Let's talk a little bit about some documentation when it comes to wound care, because I think this is where a lot of physicians fall short. The two main debridement codes that you're going to see in a lot of the wounds that aren't the more serious down to bone, fat, you're going to see 97597 and 11042. So when we talk about 97597, one of the key words we talk about is selective. Selective debridement was medically necessary to remove devitalized tissue, impairing wound healing. When we talk about 11042, excisional is the key word there. Excisional debridement of necrotic subcutaneous tissue was required to promote wound healing and reduce infection risk. Debridement extended through the dermis into the subcutaneous tissue. And I highlight the word into because that is the key. You must go into, not to the subcutaneous tissue, but into the subcutaneous tissue. Now we know that, there's no way to just stop right above, and, if we're doing that much excisional work, we're always going to go into the subcutaneous tissue, but making sure we document that word into is important. Let's talk a little bit just about some overall documentation for 97597, then we're going to talk a little bit about 11042. So this is some terminology you should be using when doing this selective debridement. The wound contains devitalized tissue, including slough and fibrin, that is inhibiting granulation and wound healing. Selective debridement is medically necessary to remove non-viable tissue and promote healing. And then the procedure itself. Selective debridement was performed using a curette, or I don't care what instrument you used, to remove non-viable epidermal and dermal tissue, including slough and fibrin. No subcutaneous tissue was removed. Measurements were done. Pre-debridement wound measurements were whatever, and the surface area debrided was this much. Continuing on, post-procedure. Following debridement, viable tissue was visualized. Minimal bleeding occurred and was controlled with pressure. The patient tolerated the procedure well. A sterile dressing was applied. Continued selective debridement is indicated based on wound response. So you could see that that word selective was used over and over again for the use of CPT code 97597. And make it bold, underline it. I always say, if you are unfortunate enough to be audited, don't let the auditor guess. Let them know exactly what you did. Let them see it, bullet point it, bold it, underline it, make sure they see it. Let's talk a little bit about documentation for 11042, the assessment of medical necessity. The wound contained necrotic subcutaneous tissue that is delaying wound healing and increasing infection risk. Excisional debridement is medically necessary to remove the vitalized subcutaneous tissue and promote healing. The word excisional, the word we removed devitalized subcutaneous tissue. These are the buzzwords that the auditor is looking for. The description, and this is what I love to call the money paragraph. Excisional debridement was performed using a scalpel or curette or whatever instruments you used. Non-viable tissue was sharply excised, again, excisional, through the dermis and into the subcutaneous tissue. Necrotic subcutaneous fat was removed. Again, the buzzwords. The deepest level of tissue removed was subcutaneous tissue. You can see here that I use the term subcutaneous tissue in every paragraph. You have to hit it home with the people who are reviewing your notes. Pre-debridement wound measurements were such and such. Subcutaneous tissue was excisionally debrided. Bleeding occurred, confirming viable tissue, and hemostasis was achieved with pressure. Post-procedure and plan, the patient tolerated the procedure well. A sterile dressing was applied. Repeat excisional debridement may be required based on wound progression. One of the things that I like to talk about when we talk about the documentation, and I talk about it in a lot of my other lectures, is laying out what we call a plan of care. Lay out exactly what you're going to be doing for your patient, similar to what a physical therapist does when they're laying out a plan of care in order to treat your patients for some biomechanical problem that they are coming in for. I had my rotator cuff repaired, and the documentation that I saw the physical therapist does laid out what he was hoping to accomplish. It should be the same thing in your documentation for the use of skin substitutes and your debridement. So the pitfalls, again, using a skin sub or an advanced therapy before optimizing standard care. 4 weeks of standard care. Telling your patient that they should not be smoking. Getting other members of the care team involved. An endocrinologist, vascular, things like that as part of your standard of care. Just continuing to put on skin subs without reassessing the response. Why are you continuing to use skin subs? Failing to document measurable improvement. If it's not getting any better and you're just putting on the skin sub to put on the skin sub, that is going to cause a failure in an audit. Treating ischemic wounds without vascular evaluation. If the wound doesn't, if it's not going to bleed, it's not going to heal. If you have a problem and you need a vascular consult, send that patient for the vascular consult. Include it in your notes. Include it in your plan of care. Why did you send for that vascular evaluation? And what are you going to do with it in order to get your patient better? If the wound area hasn't reduced by approximately 40 to 50% by 4 weeks of optimal care, reassess and document your wound care strategy. If you've gotten it better to a point and then you need to add in the skin sub, that's fine. But you must document that standard of care is there. So, in summary, non-BLA skin substitutes can be covered by Medicare, but because they vary widely in evidence quality and have a history of overutilization, CMS applies a much more heightened scrutiny to ensure it's clinically appropriate, well documented, and consistent with coverage policy. So, I want to thank everybody for attending this webinar. Um, Eric, do we have any questions out there from anyone? I also want everyone to know that this has been recorded and we will be sending out the slides if anybody requests them.
Definitely. And I don't think we have any questions. I've been monitoring and I don't think we had any come in. Does anybody have
Okay.
any questions now?
Everybody's been so nice and quiet and respectful. I appreciate that. Well, like I said, I want to thank everybody for attending tonight's webinar. Our next webinar is going to be, I believe, about mid-April. We're going to send out some notices for that. And that's going to focus more on the front office and your front office staff and how we can help provide some guidance to them. So I want to thank everybody for attending tonight. And with that, we will adjourn for the evening. Thank you so much.
Thank you all
Have a
very
great
much.
night, everyone. Bye bye.
Bye. Thanks, everyone.